We're going to start the show. And I'm going to give you a quick background. We have three excellent guests. I'm going to give you a quick background on why this topic today is so important to our regional efforts at autonomous patient safety, and why the recommendation that came out of the President's Council of Advisors on Science and Technology could make a huge difference for all of us. So I'm going to get started and just tell you quickly, here in Pittsburgh, we had one of the first regional multi-stakeholder coalitions on healthcare focused on medical error reduction. And our goal was to make Pittsburgh the global leader in patient safety. My partner in doing this was Paul O'Neill, who in Pittsburgh at the time was the CEO of Alcoa, and under his leadership, Alcoa became the safest corporation in the world. And Paul used a lot of what was available at the time in corporate manufacturing settings, and that was lean principles to make healthcare so safe. We were shocked in the late 90s to learn how many people died from preventable medical error. I think most of us were totally unaware of the death toll each year. That doesn't include those who are temporarily and permanently disabled by medical error. One thing we know, it's worse now, post-pandemic, than if we are post, than it's ever been. So we brought to healthcare the thing we knew most about, Paul knew most about, were bringing lean principles to people at the front line of manufacturing and having them solve problems to their root cause in the course of their work every day. And that was a very much an important tenet for him. But also, most importantly, there's a Harvard Business School case that's very famous, how important it was that people make their solutions to error known across the Alcoa world. And that would go from China to South America to all places in between. And sharing knowledge about what reduces error was so important to him that when one Mexican regional leader didn't share information, they were fired. So this became a cause célèbre, but that's how important it was for Paul. And early on, we were very successful. Everywhere we brought these lean principles in healthcare, we were able to achieve great success until we weren't. And we were speaking all over the world, people writing books about us. We thought we had cracked the nut, and we hadn't, because within healthcare, the burden on the frontline staff to actually do and follow through on the principles of lean quality engineering in their daily work did not allow spread and sustainability. So everything we worked on, all our achievements, when we pulled our coach, went back to baseline. We thought we should have a banner, back to baseline. So we've been, as everyone in the country has, not only disturbed by the rise in medical error during the pandemic, and it's being sustained, unfortunately, but the twin disasters. The rise in medical error is a cause and effect of the morale problem with our workforce and the number of people in medicine, nursing, and many other health professions who are so disillusioned, they literally plan to leave. We looked at surveys of some of our local doctors, 48% in their satisfaction survey said they wish they'd chosen another profession. That sort of breaks our heart. So we said, we've got to go back to the drawing board. We'd moved away from working on medical error in hospitals. We moved to an agenda where we kept people out of hospitals. We were very good at that. We got a lot of money to demonstrate that there were many ways you could keep the populations who are most likely to go in and out of hospitals. But that wasn't making me feel good as the error rate kept climbing in hospitals. Our staff became very disillusioned. They couldn't perform their duties clinically in a safe way. And then, as you know, also the increase in public mistrust. So we looked at other industries, right? Look at the safety curve in mining. What most people agree is the most hazardous industry in the world. That's their safety curve. And the same with aviation. And it honestly doesn't matter. We looked at quite a few industries, and what did we find? They weren't asking workers at the front line in these other industries, the primary responsibility wasn't at the front line. And they didn't rely on learning collaboratives, even just checklists, any of this to make their industry safer. They used technology. And what they did is build in autonomous infrastructure so that people worked in safer environments. So, I mean, the one thing we know, our miners, our pilots, our astronauts, they're not responsible for fixing their equipment or the machine in which they travel. We make the machines and the environments as safe as we can autonomously so they can do their work. And it's what we have not done in healthcare. We have not built a safer environment to prevent injury, both for patients, of course, but also for workers. So we wanted to test an idea. We wanted to say, what will change things? What would be the most dramatic change? And we had this idea, what if academic medical centers actually reached across in certain innovation hubs to their academic tech powerhouses and started to develop safety solutions for healthcare, particularly autonomous safety solutions to prevent harm before it occurs, as other high-risk complex industries have done. But we didn't know if there was a taste for this. So we started offering awards at existing hackathons, ideathons, business school, medical school competitions in select innovation hubs that we had chosen to see whether people really wanted to compete for patient safety technology awards. And we were dazzled. Our first two our first two takers were South by Southwest and MIT, and we figured, okay, we think we've got it. There's a tremendous interest on the part of faculty and students from many different disciplines. And let me underline that. We're not relying on health professions. We're getting lots of different professions interested in this topic. And we get lots of takers in all of our competitions where we've offered the award. We've gone way beyond now our immediate target innovation hubs. This isn't moving, Robert. Okay, I'm having trouble moving the slides, so that's not helpful. Okay, so I mentioned what Paul O'Neill, the famous business school case, it was the not sharing of progress that cost the job of one of his most successful regional leaders. And the issue we have in healthcare, these are all the different players who have some responsibility somewhere for a little piece of patient safety. But we have no one central federal agency that can spread and sustain progress. And that has been a huge problem. We formed a coalition. The idea that we should have a federal agency is not new. We're not claiming originality. This has come up for decades, but never got affected. And we put a coalition together of 80-some organizations representing all the key stakeholders in healthcare, all of whom signed on to support a national patient safety board. Modeled after what aviation has, clearly, not only the NTSB, which everyone knows, but even more importantly, CAST, the Commercial Aviation Safety Team. Why? Because they spend all their time looking at research, on looking at updated data, real-time data, submitted by all the airlines who, as an industry, have committed to safety. I don't want you to miss any of those caveats because they're highly influential, to identify and anticipate harm across the industry, and then to identify the causers and precursors for harm and create solutions. So we're very excited that, as I mentioned, PCAST just came out with recommendations for patient safety they're sending to the White House. We have some leaders here, and you'll get to meet them, who are on the working group that came up with the recommendations unanimously endorsed by PCAST and sent to the president on September 7th. The #1 recommendation calls for a national patient safety team. So coming back to Pittsburgh, how many people in Pittsburgh even know we're actually a center of safety research, discovery, and innovation. And this is pretty critical. We have a number of companies here that made those industries, whether it's aerospace, mining, transportation. A lot of the safety enhancements that we take for granted came from Pittsburgh. That is part of our heritage. There's actually a plaque right in Market Square about our leadership in industrial safety going back to 1917. But we also have a lot to build on here, a lot of infrastructure that we can build on in healthcare and in healthcare safety tech. So it's not like we're starting from zero. We have been successful in a number of areas here. And again, let me emphasize my excitement that when academic medical centers with their life science expertise can reach across and partner with autonomous technology leaders in a region, I think we have the ingredients for amazing progress. So having this National Patient Safety Board or team to spread those discoveries and develop a commercial market for what works is absolutely essential to the work we do here at the Regional Autonomous Patient Safety Initiative. So one reason you're all here, one reason we're reaching out across our region, we think we're a key innovation hub. And maybe, I know this is aspirational, maybe we should be the global hub for safety technology, following on Alcoa's leadership as the safest of all corporations under Paul's executive scope. So anyway, I'm going to turn this over now to Robert to introduce our guests who have a lot to say about how important it is to have a national entity that can spread and sustain progress.
Thank you very much, Karen. And I'll begin by introducing the panel, beginning with Ken Catchpole. He is a endowed chair at the Medical University of South Carolina. As a human factors engineer, he has spent over 15 years studying and improving safety in acute care settings across the world. And the other panelists very much aligned with what Karen was saying about learning from the safety record in transportation and in aviation is Chris Hart. Chris has been a leader in transportation safety throughout his career, both at the FAA and at the National Transportation Safety Board, and also as a pilot. He became chair of the NTSB in 2014, and he's also the founder of Hart Solutions and a current board member of the Joint Commission. As a safety leader, he was appointed as a member of the President's Council of Advisors on Science and Technologies, a patient safety work group bringing safety science principles to healthcare. And Julie Morath is also a member of the PCAST, a patient safety work group. She has over 3 decades of experience as a healthcare executive, following her work as a nurse, where she specialized on mental health. And among many other patient safety accomplishments, she is also a founding and current member of the Aleutian Leap Institute at IHI. And Chris, I'll begin with you by asking, as an aviation safety leader and former NTSB chair, what were your observations of the PCAST patient safety work group recommendations and deliberations?
Well, thank you, Robert, for that very kind introduction, and thanks to you and Karen for inviting me to be here in the first place. I really appreciate that. The danger is once you get me started, you're going to have trouble shutting me up, because I love talking about this stuff. So I'm excited to have the opportunity to be on the board of the Joint Commission and then also on the Patient Safety Working Group, and to bring my aviation expertise to try to improve healthcare safety, which, despite a lot of effort by a lot of smart people, the numbers are still going the wrong way. So PCAST is one example of trying to move that needle. And one of the ways they're trying to do it, obviously, is to bring federal attention. As Karen said, there's really no centralized federal location to go after healthcare safety. And so one of the huge aspects of the patient safety working group was to bring federal attention to this problem, and specifically to get people to start collaborating, because healthcare has such an individualistic culture. I do it my way and I do it great my way, and don't tell me how to do it your way, because maybe your way works for you, but my way works for me. So don't bother me with that. So it's to get an industry that is so individually oriented to come together and collaborate, because to me, one of the key messages from the PCAST is collaboration, and that follows along the lines of what Karen said. We've exacted pretty much all of the perfection out of the people that we can expect to get from the people. Now the question is, can we make the system, the circumstances in which they operate, more friendly to what they do, so that they can do it better, and so that they're more likely to be able to respond to the reality in healthcare that a lot of situations are not friendly to error, and therefore it's very important to do it right the first time, every time. And in order to do that, it's not just a matter of the people doing the right thing, it's a matter of the situation that they're in, favoring it to help them do the right thing. Very much as Karen said, it's not just the people, because you can get so much perfection out of the people, but if you're not working on the systems and the equipment and the procedures that they're dealing with, then you haven't solved the problem. And that's why I think the numbers are still going the wrong way, despite decades of effort by a lot of smart people, is because they're aiming at the wrong target. They're aiming at making the people perfect, and there's only so much perfection you can get out of people. There is very little emphasis that I've seen on making the systems better, and that's one of the things that PCAST is helping with significantly, and bringing federal leadership into that, I think, is very important.
And very similar to your points about the value of a multidisciplinary thinking, could you also talk a bit about how the public-private commercial aviation safety team operates, Chris, and how they gain consensus on solutions to prevent accidents and injury?
Sure, because this is a story that I think healthcare can learn a lot from. So from the 50s to the 90s, the fatal accident rate in aviation was coming down wonderfully, and it was coming down mostly because of new technology. So, for example, jet engines were far more efficient and reliable than piston engines, because piston engines vibrate so much just by definition. Jet engines don't, and so that lack of vibration caused the jet engines to be much more reliable, and that caused a huge reduction in the accident rate. Simulators, so that you can practice things, you can have pilots practice things you'd never want to practice in a real airplane because it's far too dangerous. So simulators help to bring that down. The eagerness of the industry to nobody wants an airplane to crash. Let's put it that way. It's not like financial disasters. Some people actually benefit from financial disasters, but nobody wants an airplane to crash. So when aviation put these new technologies in place, and automation is another new technology that really helped automation. Automation has its downsides, but if done properly, collaboratively, the key word that I'm going to keep repeating is collaboration. If it's done properly and collaboratively, it can make a huge positive difference. So the point is that by the early 90s, the improvement resulting from automation and simulation and jet engines, those improvements were asymptotically approaching their improvement limits, because every improvement has a limit beyond which it can't offer any more improvement. So they have their asymptotic improvement limits, and that's what they were approaching in the early to mid 90s. And meanwhile, the FAA is projecting double the volume of flying in the next 15 or 20 years. So a little simple arithmetic tells you flat stuck accident rate times double volume means you are going to see twice as many smoking, burning airplanes on CNN. And that's what scared them. And they viewed that result as totally unacceptable. And what can we do about it? And here's where the administrator of the FAA came in and made a key statement, because he's the one who runs the regulator. The FAA is the safety regulator for aviation. He's the one who said, we are stuck on a plateau, but the way to get off of this plateau is not by giving me, the regulator, more money. It's not by giving me the more power to enforce. It's not by giving me a bigger stick. It's by having the people who are in this complex system work together collaboratively to figure out how to make this complex system work better, so that everybody can do their job more efficiently, more effectively, and more safely. So that's what CAST was all about, Commercial Aviation Safety Team. excuse me, was all about how can we operate this complex system of connected subsystems more effectively and more efficiently and more safely. And the way we need to get off of this plateau is by working collaboratively to do that. So they brought the airlines and the manufacturers and the pilots and the controllers and the airports and the regulator, and all of the key players came together around the table, and the entire operation was completely voluntary. And that's crucial, because I think if it had been mandatory, it wouldn't have happened. And I also think that if the regulator had not been part of it, it wouldn't have happened. But the regulator is actually the co-leader of it. They have two co-leaders, that one is the regulator and two is somebody from industry, are the co-leaders of this voluntary program. So here's the success story. They took that flat stuck rate, which a lot of safety experts at the time thought was about as safe as it would ever get, took that flat stuck unimprovable rate and improved it by another 83% in less than 10 years. What an amazing success story that was. And what caused that? What caused that was the process change of going to collaboration instead of doing it my way. And so take off my me hat and put on my system hat, and we can together figure out how to make the system work better. And that's to everybody's benefit. And the reason that voluntary works is because everybody benefits from being part of this collaboration. So those are the lessons that CAST really has shown, not only to healthcare, but to a lot of other complex industries too, is that if you work together and think system, then you can make the system better and everybody wins. And that's why voluntary is still working, because everybody is benefiting from it. So the key, the tough part was getting people to collaborate who didn't previously collaborate. Like, how do you bring labor and management, who are always beating up on each other? We're seeing that big time right now. How do you get them to come in the sandbox and play together? How do you get the regulator? Nobody likes the regulator. So how do you get people to work with the regulator and work together? How do you get the airlines and the manufacturers? Because if there's a crash, then they're going to be in court beating up on each other. Your fault, your fault. How do you get them to come and play in the sandbox together? So of course, one of the principal challenges with collaboration is human nature, which is everybody thinks I'm doing great. You need to get your act together, then come back to me, and then let's talk. I mean, how many times have we heard, I don't need the marriage counselor. You're the one who's got the problem. You need the marriage counselor. So that they really showed that collaboration is tough to do, but they managed to pull it off. They had two champions. One was the head of the FAA, as I mentioned, and the other one was the head of safety at United Airlines. Those two champions convinced everybody that there's something in it for them and got them to do it. And then when they did it, they realized, again, voluntarily, they realized that, gee, there is something in it for all of us. And that's why it's still going to this day after more than 20 years and still improving safety. So it's been a huge success story on the power of collaboration.
Yeah. And Ken, you also wear this systems hat as a human factors engineer. What do you see as the significance of the PCAST recommendations? And also, since you've been such a leader in the patient safety research, how do these recommendations differ and advance the field of patient safety inquiry and discovery?
Thank you. Yeah, and thank you for being here. And it's wonderful to follow somebody as kind of clearly experienced and astute and expressive as Chris. So many things there that I was nodding with. And I think I'm going to take your lead and I think riff off some of that. So, I've spent the last 20 years trying to think about human factors and systems engineering approaches to safety in healthcare. And one of the things that, and this was kind of sparked early on by the kind of acknowledgement that the problems of patient safety go beyond the abilities of individual clinicians, or indeed kind of general clinical expertise. That clinicians aren't necessarily systems thinkers or systems engineers. They can be trained to do that, but their training does not naturally do that. But what we've seen over the last I would say 20 years is an increasingly the adoption of the idea of error being a professional problem that can be trained out, or other ways, rather than actually seeing it as an engineering problem. And so what I've seen is this real challenge with crossing this divide, as Chris says, being able to bring the collaborators along, including experts from other industries, or indeed just industrial experts in systems engineering. I've managed to do that myself through a very non-standard way of working. I'm a human factors systems engineer in the Department of Anesthesia, which is relatively rare. And so the first thing I think this does is reset that idea that this isn't just a problem of clinicians. It's a problem of systems engineering and of technology, is integrating technology with human performance and making sure that we design the technologies and automation to address the clinical problems, but working very much across these ideas of systems and systems thinking and systems engineers, and clinical expertise to solve patient safety problems. The second, I think, thing this really acknowledges is that, unlike lots of other industries, healthcare safety problems are vastly distributed. You have the same or similar accidents caused in similar ways, but distributed, across across the world. So you might have a device that's creating problems, or a procedure or policy, a way of doing things that's consistently creating problems, but that problem is distributed across the, across hospitals and across individuals and across, nationally. And we've come across some of these devices, for example, that predispose certain types of errors, but nobody's joining the dots because there isn't a way of doing that. And so I think the second thing this does is acknowledges that actually this needs to be dealt with, in a national way, that we, in a much more joined up way, in a regional way, in a national way, in a way that I think we're not doing right now. So where do we go from there? So then it's really about bringing, these, I think I'll also add actually a couple of other caveats, and this is why, I think that, we don't know all the answers to this. Absolutely, lean is a really, really important part of how we can move forward. Absolutely, we need to learn, things from aviation, and I think there's tons of things that we can learn, but also healthcare is different. And so it's about actually acknowledging that these are big challenges, that these are challenges of, at a kind of national level, the challenges that there are experts that we need to be bringing into healthcare to understand the unique challenges of healthcare, so that we can collaborate across clinical and technology worlds to develop technologies and approaches and processes and systems engineering approaches that will both address the unique challenges of healthcare, such as patient-centered care and the incredible variation that we have in the delivery of care, and the, I think, unique pressures we have, but also that can bring in systems engineers who do have a lot to offer, and all sorts of other people who will, who we can bring into this collaboration, as Chris says, the incredible expertise that we have available that we're not utilizing right now. So I would say it's most importantly, I think it's those two things. It's about having a joined up national approach, and about acknowledging that this isn't just a problem of clinical care that can be solved only by clinicians.
Thank you. And Julie, Chris also noted in his earlier comments about the differences in the incentives that exist in the aviation industry compared to healthcare. Could you talk a bit about what financial incentives exist today related to patient safety, and how would the PCAST recommendations potentially change that?
Mm-hmm.
So the financial incentives are definitely not my area of expertise, but I think one of the challenges with healthcare is that there's always more and more demand. People don't stop getting sick, and the more, the better the ways we have to delivering care, the more care we want to deliver. Also, patients get more complex, the better we, the better we get at delivering, delivering basic care. So, and I think this is one of the contrasts with other industries. And so that has an impact on how we decide and where our resources are expended. Fundamentally, how do we use the right resources to give the most number of people the best quality of life for the longest period of time? And so there's a real fundamental issue that I think I would argue is different from other industries, in that those challenges don't stop. We don't, if we can ground aircraft that are unsafe, we can't really close hospitals that are unsafe without potential harm in other areas. And so in that respect, I think but I think there are also kind of really perverse financial incentives. As you can tell, I come from the UK originally, and in the UK, or with any kind of socially organized or single payer, let's call it a single payer system, then patient safety is a much greater priority, because you have to be caring for people who you injure. Whereas the US health system is not necessarily configured that way. And I would recommend that, watching Bleed Out, which is available on HBO, is a really good example of how there are sometimes perverse the financial incentives around how we keep our patients safe. And I'm definitely not a politician to be able to answer those questions, but I think that creates certain challenges, that the US system has to deal with. Ironically, I'll say that actually, having worked in both systems, there are a lot of work going on in Australia. That there is the problems that clinicians have on the ground are remarkably similar. But I think how we deal with injured patients and the financial repercussions for that, and their experiential the experiences that what they have, and of course diversity and inclusion, in that a lot of the patients who we injure are also disadvantaged through our systems in other ways. I think all of those things are definitely part of the discussions we need to have around safety, which I also think somewhat differ from the other industries, but nevertheless really, really important to have.
Right, exactly. And Julie, especially given your work with the PCAST patient safety recommendations, could you talk a bit about how would those recommendations potentially change some of the incentives, and what were the work group deliberations around this topic?
Yes, if you would allow me, though, I'd like to just make one comment, and it's exciting to be here with you in Pittsburgh. In the late 90s and 2000s, I had the privilege of working with Paul O'Neill, and he changed everything. So, you think as a clinician that harm is a byproduct, an inevitable byproduct of the complexity of the environments we work in. And Paul was very clear. Okay, what are the theoretical limits of what is possible if you look at safety through different lenses? And that involves engineering and the sciences and others that we had not in the past collaborated with. And that kind of changed my life in terms of how one addresses operating a healthcare organization. So just take that into incentives. You mentioned our incentives in the US are often perverse. And I think the hydraulics that we have of reward and penalty just invite mischief. People begin to game the data and the reporting, and it just inspires trouble. And until we get this right and figure out the incentives that really look at the systemness of how we work instead of the point spot failures and successes, we will be limited in our ability to move patient safety forward. I used to not speak of ROI or money because I thought it contaminated the work of patient safety. Now, that was pretty naive, but my colleagues with the PCAST work group have reinforced that we need to model, connect the dots, and look at this in a very different way. And I think the recommendations that came out of the work group and that are now on the president's desk and approved by PCAST is going to change the frame by which we look at how we incent performance in healthcare. Now, obviously, we didn't go into granular level, but what you'll see in the recommendations is that the HHS secretary should require CMS to develop, implement, continually evaluate mechanisms to incent hospitals to employ evidence-based patient safety solutions, starting with high harm areas. And I think the key operant word here, is Chris and kept going back to, is the requirement for systemness and collaboration, and that it doesn't rest in one point. So what we have in the recommendations is that there'll be no reimbursement for care if there is harm and the known best practices are not in place. But if there is harm and they are in place, there will be not only reimbursement, but also looking at the sequelae of care that may have been required. So that helps people, I think, to become more honest in talking about and creating greater transparency of what we're up against. And the point I want to make with this is that for our scientists that are in the audience, if we can begin to shift to a more inquiry-based implementation science, we know in many instances what to do, but we can't do it. We're not working together, we're not collaborating. And then when we do make change, it's these big bang rollouts. And so if we cycle out, we've got the opportunity to iterate, learn, simulate before we go live in a really high risk area. So I think the recommendations create a framework that will free people up to think about and work differently. Now, there are specific incentives that I applaud, and I think Chris would agree that we wrestled with a lot, and that is around how we incent and support those caring for underserved populations, i.e. payment, safety net hospitals, rural hospitals. And while the general focus in incentives was that we preferred incentive to penalty, however, there are mechanisms that are called out, like CMS conditions of participation, should they be needed to give a nudge to those organizations that are slower on the uptick. So for this scientific community, I think there will be incentives to have partnerships with hospitals and federal public entities to begin evidence generating activity. In part, we know a lot, but we don't know what we don't know. So this includes measures, solutions, interventions, translational research.
And Delise, on the note of solutions, especially reflecting on your executive and a nursing career, what solutions would you want the National Patient Safety Team to prioritize to in Karen's words, to build them a better airplane.
I can chime in
Yeah.
on that one in a hurry. I
Yeah,
told
go
you
ahead,
I
Chris.
have trouble shutting me up, but I want to put an
I'll interrupt you. How's that?
that works. I want to put an
Okay.
explanation point on something that Karen said, which is the flow of information, because information about errors and near misses is the primary source of information that CAST use to find out what's wrong and what needs to be fixed. Usually that information doesn't tell you about bad people. It tells you about bad procedures, equipment, practices that the people are being forced to follow that aren't very user friendly. And so every time you hide an error and a near miss, and that's what they typically do with information about errors and near misses in healthcare, is sweep it under the rug as much as possible. Every time you do that, you lose an opportunity to improve the system, to make the system more user friendly. And so the flow of information is absolutely critical to again, to put a finer point on what Karen said. And I'm glad to see that these recommendations have some references to better use of information and not just hiding it.
You know, Chris, we had this discussion, debate over the past year and a half, and I think one of the things that a national patient safety team and inherent in our recommendations is developing a culture of safety. Clinicians have an additional burden when things go wrong of having to keep things secret. The event itself was an accident, but not talking about it is intentional, and it does cause harm both to the patients and families involved, as well as the clinicians that were proximal to the event when it occurred. And a culture of safety that is a thread through the recommendations opens up the space for people to report, to talk about, and collaborate across all the divisions that kept us apart historically. And that opens up the flow of information so that we're continually learning and responding in a productive way to that which we then see needs to be taken care of. So I think in terms of the workforce, reducing the burden of secrecy and having to pretend everything is okay when it isn't is a big step, and it addresses, I think, some of the issues that we're having with workforce rethinking their commitment to healthcare. And it doesn't have to be that way. And we've got solutions, I think, embedded in these recommendations.
Exactly. And Dr. Bisage, I'd like to ask you to ask the panel any questions or comments you have.
Yeah, Chris Hart, I'm sorry that I don't know who you are, but your perspectives are clearly interesting.
Well, thank you.
What is your background?
I'm an aerospace engineer by training. My mother told me the first thing I ever drew was an airplane, so I'm an airplane addict. I'm a pilot as well. So I spent a lot of time at the FAA and a lot of time at the NTSB.
Okay, and where are you physically located? I mean, where do you live?
I'm in DC now.
Okay, all right. Good to know. Thanks.
Sure.
And Lenny, you have your hand up as well.
Yes, thank you. You were talking about sort of having a common goal, which in aviation, nobody wants airplanes to crash, but in healthcare, it can be quite different. I'm doing a study of how some hospitals in New York City responded to COVID, and one thing we found is that there was often less data sharing and so on because of fears of it would affect their reputation, or the data is very valuable. And the other question I had was about government's willingness to regulate things. So around 2012, usability experts for electronic health records tried to get government to regulate more about usability design, and that was pretty much refused. A lot of people think that EHRs, there's regulatory capture and EHRs. And we were told things like, you know, we don't want to do this so that American companies can sell overseas and things. So how do we get the real incentives and regulations to all be coordinated?
I could try a first pass in response. You know, the recommendations that are in front of the president, one of the things that was really grappled with at first is who's accountable for this? Where's the accountability rest for the safety in healthcare? And that's where the National Patient Safety Team, the focus on a safety coordinator reporting directly to the president, these kinds of recommendations generated from that conversation. And what you'll see in the recommendations that I think will help open up the space of reporting are accountability, transparency, a learning ecosystem, and a shared accountability through, and it's a threads that go throughout all the recommendations. And if those threads are woven together, we're going to have a tapestry of improved patient safety, and we'll be able to perform as we are capable of doing if we put all our talent and intellect together.
Okay.
I'm going to follow up on that question because I think that's a really good question. And one of the challenges I see is that there's a kind of, I think I'm also going to take in something that Chris said about the data, that one of the challenges we have in incident reports is that clinicians don't tend to report the things that other people do, that systems engineers would. And so there's a massive lack of reporting around how things like EHRs or other devices can end up with decision-making failures that lead to harm. And I've got some anecdotal evidence of this. One of the things is we don't know how many devices create the problems for the clinicians because nobody reports them. And people don't report them because they don't know to report them, but also because there's no change that happens. No one does anything about it when they report, and as well as, you know, the wider concerns about reporting. So there's this kind of whole lack of data around this. And as a result, taking accountability beyond individuals to, you know, to systems engineering problems, to device manufacturers, to all those kind of things, you know, or to organizations is much more challenging, which is why we end up blaming and not moving beyond the idea of individual blame and training and professionalism and all those things to, well, actually, we need to have better usability standards for EHRs. You know, Raj Ratwani is one of my colleagues at MedStar. He's done tons of work on you know, David Bates, some of those other people, around the usability of electronic health records. So there's a real, you know, so there's this kind of whole issue with it's kind of the land of the blind. We don't really, because we don't have data on it, because the people in the organizations, you know, aren't necessarily exposed to the systems engineering type problems or usability. They don't know to report it, and so we don't know to do anything about it. So one of the wonderful opportunities that this report offers, and the national, you know, joined up approach to this, is that it does allow us, I think, to start peeling away, to start introducing and developing these, you know, these lost ideas around systems and engineering in healthcare systems. We actually need to have engineers working alongside clinicians in all sorts of different ways. And I think that this report really does help drive those ideas.
No, it's taking reporting and information solely from the responsibility of the individual working in the environment to look at innovation and development in our transfer of information from devices, from the electronic medical record, to reduce that additional burden and also have more accurate and timely information flowing into the system to understand.
Absolutely, yeah.
So two thoughts on that. One is that the aviation world is very good on taking in users and bringing them into the design phase so that what ultimately comes out of the factory is friendly to the end user.
Meaningful. Yeah.
I hear so many complaints about electronic health records that is a clear sign that the end users, the doctors, the nurses, the whoever else is using it, were not involved in the design of it, and so what came out was not so user friendly. And so now I hear complaints about it takes more time to deal with a patient because this actually slows me up rather than helping me. And no wonder people are leaving, because their equipment is not designed to be user friendly, and they're frustrated by trying to use their equipment every day. So that's one sort of today comment. I'm going to give you also a tomorrow comment, which didn't make the recommendations because it's not really in their bailiwick. I'm an attorney, and I know that litigation discourages. The main reason people don't share information is because they're afraid of the litigation. They're afraid of it showing up against them in court. And so that's one of the huge challenges. And my recommendation for that, which again is not in the bailiwick of the PCAST, is to eliminate litigation in the compensation process and compensate as a no-fault process, like very much analogous to what they do in workman's comp and what they do with certain vaccines. And so it's not a matter of proving fault, because there is no single point of fault. There's a lot of things that went wrong in the process of things going wrong, and trying to prove fault through the litigation process is totally unproductive. And not only that, but it discourages people from sharing information because they're afraid it'll be used against them. So I am, as an attorney, I'm not going to make many attorney friends, but I am totally opposed to litigation as part of the compensation process, and think the compensation should be done by no fault.
While that didn't make it into the recommendations, what did in recommendation 2 is the notion of the use of candor, or a CRP, communication resolution process, when there is harm. And that is very principle-based, ethically based. And as that develops and the organizations pick up on that, one of the things that is a natural extension is the litigation question. So I'm hoping we'll grow it.
But a lot of lawyers have big houses and big cars because of that litigation, and that's why it's going to be a huge, huge challenge to try to get rid of it.
And a lot of your comments are also beautifully making the case for why we need a national patient safety team. And Julie and Chris, would you like to comment on what next steps you see for advancing these recommendations, and have they been in front of the president? And then Rebecca, I'd like to ask you for the final question, and then we'll close out the session.
Chris, do you want me to go first?
Yes, please.
Okay. The National Patient Safety Team, I think the real criticality of this is that the creation of urgency, accountability, and inclusion of all relevant stakeholders, and that they will have the responsibility for the orchestration and oversight, and requiring innovation at all levels. It balances out perfectly with what Karen spoke of at the beginning with the National Patient Safety Board, that there is a mechanism for continuous learning, improvement, and accountability that would flow through a patient safety system. And that's the key word there. Did you ask what's next as well?
Yes, yeah.
Chris, you may have greater insight than I, but I know the president has been briefed and was favorable, and we're awaiting to hear. I understand that the work group's going to be pulled back together shortly. We hope that we can weigh in around some of the implementation. We had very complementary and distinctive expertise, but what we do have was a real shared passion about not harming people and getting defects out of care and learning and improvement from a whole systems approach.
Yeah.
Chris, you're more elegant than I am on that.
Well, thank you. I doubt if that's the case, but thank you anyway. So there have been attempts to bring increase the federal involvement in healthcare before, and they haven't been very successful. So I guess I'm just in a wait and see posture to see what the president, I know he's mentioned many times that this is high on his list. So I'm going to take him on that and wait and see how that high on his list translates into real action. And so I don't have a good answer for you yet. It's kind of a, we'll see, but I think we did an amazing job of lighting the way. So now we'll have to see if people will follow.
Yes,
You know,
and
I think it's important. Oh, I'm sorry.
no, I think I'm similar to what you were going to say, Julie, around advocacy. With my policy hat on, I just want to encourage everyone to write to the president, say that these PCAST patient safety recommendations are meaningful, and we need action to create the NPST now. And also, as Karen mentioned earlier, JHF also convenes the National Policy Advocacy Coalition for the National Patient Safety Board, and in the link you'll see a way to join that coalition, so your organization can become engaged in that type of national advocacy as well. And just in the final 2 minutes, I also just want to note some upcoming RAPS salons that we will be having on November 16th from 12 to 1. We'll be featuring the work at Pitt and UPMC in terms of how they are on a pathway around a research, development, and commercialization as it relates to patient safety. And then on December 6th, we will have a salon featuring young startups that are engaged in patient safety R&D. And as always, the link is in the chat for those upcoming sessions. And you'll also see, as a final reminder, a way to submit for some seed funding to help advance all of your early stage of work around patient safety research development. And again, those seed grants are due this coming Monday. So if you have any final questions about how to submit applications for that seed funds, please don't hesitate to reach out to myself or our team with any questions. And we'll end exactly on time. And just thank you all and for attending. And a special thanks to the phenomenal panel. Really appreciate it. Ken, Chris, and Julie, thank you.
Thank you for inviting us.
Thank you. It was nice to be with you.
And really great discussion. Thank you.